Welcome back to Diabetic Foot Files, where we don't just treat wounds, we decode them. And today's episode is called Water in Wounds because water, we all love it. It cleans, it refreshes, and it actually heals, or at least that's what we're told. But you know, it's been in the news now lately. The same water that soothes our skin can actually quietly colonize our wounds. So let's talk about you're soaking your foot in the beach, which you're not supposed to do, or a hot tub, or even doing a quick dip. And that is something that could stand between a patient having a wound or having an amputation at times because they actually I think I saw it in the news today. Is something on Long Island about the Vibrio Volunticus. I know I didn't pronounce that well, but that bacteria, because it's been causing necrotizing fasciitis, the flesh-eating bacteria. It's the flesh-eating bacteria. It's one of the flesh-eating bacteria. Okay, so that's what's been going on because it's in the beach water right now. So let's talk a little bit about water. Water, is it clean? Most of the time, it's not. Okay. So let's kill the myth about that. Water is not sterile. Water is not. Your tap water is not sterile. Water is not sterile. Even the clearest water contains bacteria, fungi, parasites, and biofilm forming organisms. And the key is water is a microbial highway, especially in oceans, lakes, rivers, hot tubs, and pools. But for a healthy person, this risk is quite minor. But for a diabetic patient, these are high stakes gambles. So, why? Because in diabetic wounds, they are hypoxic, they're already immunocompromised, they're often neuropathic because the patient won't be able to feel the damage unless it gets really severe, in my opinion, and prone to colonization because their immune system is compromised and they can get an infection that can progress to an infection if not taken or treated appropriately in the time frame that needed to be done. So let's talk about the different waterborne bacteria that can harm these wounds. So let's talk about the real villains. So let's talk first salt water because everybody loves the beach, right? So like I was saying in the news, they have Vibrio furunculicus. Vibrio furunculus, okay? And this is not just another wound pathogen. This is one of the most aggressive limb and life-threatening bacteria that you will ever encounter in wound care. Why is it dangerous? Because it's in warm seawater, it can be in brackish water, and it can actually even be in raw seafood, especially in oysters. And it thrives in tropical climates. It has a high prevalence in Caribbean like areas, and it enters through open wounds exposed to sea waters, minor cuts or abrasions, even insect bites, and sometimes through indigestion, like we said with oysters, that can get through your bloodstream. But like when sometimes people go to the beach and they'll have a little scrape from anything at the beach and they don't get it handled or they don't take care of it and then they get some cellulitis and it can get out of hand. I saw somebody who had sepsis from that. And clinical behavior, it causes rapidly progressing necrotizing infection. So this organism moves quite fast. We're talking about pain out of proportion within hours, rapid swelling and erythema, the hemorrhagic bullae, which is a key red flag, the skin turning dusky, purple, and necrotic, and the crepitus may or may not be present. But this can quickly evolve into necrotizing fasciitis as well as sepsis. And here's the part that's quite terrifying. Sepsis can develop within hours, not within days, within hours. And the mortality rate can exceed like to 30 to 50% or even higher if there is delayed treatment, if the patient has liver disease, or even if the patient is immunocompromised or diabetic. So why are our diabetic patients at higher risk? In our world, this is very critical because patients with diabetes, peripheral arterial disease, chronic wounds, liver disease, like we said, they have impaired immune response, reduced perfusion, and decreased ability to contain the infection. Just like how, sometimes your body, with a foreign body, they can try to contain that infection. So instead of a localized infection, it becomes a systemic, overwhelming invasion of the body. So what is the pathophysiology? Why is this vibrophonoculus so aggressive. It produces cytolysins and proteases, which causes tissue destruction. It causes endothelial damage, which causes a vascular leak and these hemorrhagic bullae. It causes rapid bloodstream invasion, which will result in septic shock. And these iron-rich environments, like in liver disease, it will enhance the bacterial growth. So this is why the tissue doesn't just get infected, it gets destroyed from the inside out. So how would you manage this? It's a surgical emergency, actually. You do not wait for okay? So immediate steps with the patient will be placed on broad IV spectrum antibiotics, okay? Urgent surgical debridement, ICU, most likely level monitoring if systemic signs. If it is delayed, there is a huge risk of limb loss or death. Now, the next organism is Vibrio parahemolyticus, okay? And this organism is more common but less dramatic, but still important. So the primary role of this bacteria, Vibrio parahemolyticus, okay, forgive me, is commonly from raw or undercooked seafood, so it can cause a GI infection. So it causes watery diarrhea, abdominal cramps, nausea, vomiting, fever. So it's usually self-limiting. But in wounds, right? Just like fibroblasticus, it can enter through cuts exposed to seawater, but it is less aggressive. So its presentation is milder, mild to moderate cellulitis, local pain, redness and swelling, rarely necrotizing, which is a good thing, right? We don't want the necrotizing. But it can become serious because in immunocompromised patients or diabetic patients, it can worsen. It can mimic a more aggressive infection and it requires close monitoring. Okay, but it generally does not explode clinically like Vibrophalangiticus, okay? Now, freshwaters like lakes and rivers. So we have the bacteria Aeromonas hydrophila. So this organism lives in lakes, rivers, floodwaters, and even poorly chlorinated pools. And it's far more aggressive than people expect. So the clinical behavior of Aeromonas, 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 forgive me, hydrophila it is unlike a slow burn pathogen. This can invade rapidly after exposure, can cause severe cellulitis within 24 to 48 hours, can progress to myonecrosis, fasciitis, as well as systemic infection. And it can resemble necrotizing fasciitis, especially early on. Why is this bacteria dangerous? It produces a cytotoxin and hemolysins, which causes tissue destruction as well, can invade the deep structures quickly and thrives in traumatized tissue like cuts, abrasions, or ulcers. And here's another big clinical trap. It often starts looking like just simple cellulitis. And so it gets treated casually, and the delay, that's where things can go wrong. It also has a hidden problem of antibiotic resistance. Aeromona Aeromonas hydrophila is often resistant to penicillins and first-generation cephalosporin. So if someone gets a cut, standard cellulitis coverage, right, it may fail silently while the infection progresses. So better coverage for these type of bacteria is fluoroquinolones, and everybody knows the risk of fluorals, right? Third-generation cephalosporin or like Bactrim, which is case dependent. So in our high risk patients, you got to remember that, okay? Because it rarely these bacteria stay superficial in diabetic patients, okay? Now, our next one for the fresh water is like fresh water, like our lakes and river, is my favorite bacteria, Pseudomonas aeruginosa. Okay, so that's our green monster, right? So just like Aeromonas is aggressive, Pseudomonas aeruginosa is quite strategic. Okay, it thrives in moist environments, macerated skin, chronic wounds, dressings that stay too wet in between the toes and plantar surfaces. I think it's just so erythrom Pseudomonas aeruginosa bacteria is just so out there, dramatic. Look at me. Yeah, maybe that's why I like it. Maybe this is an organism that says if it's wet, I'm staying. Right. So The clinical behavior of this organism is quite chronic, it's stubborn, and it delays healing. It rarely explodes early. Instead, it colonizes first, it forms this nice little biofilm, it becomes resistant, and then slows the healing over time. And this is how you get chronic non healing ulcers, persistent drainage, and recurrent infection cycles. It's quite common, okay? So the biofilm, that's a big key concept in Pseudomonas aeruginosa, okay? The biofilm is where the bacteria can encase itself in this protective matrix. The antibiotics struggle to penetrate and the immune cells cannot effectively clear it. So even if the wound looks, in quotations, what we think not so bad, if it still doesn't refuse to heal, that's a possibility, okay? And clues that we should never ignore when it comes to Pseudomonas, this greenish drainage, the sweet, fruity odor that I've never experienced in my entire life, still haven't, okay? It's 2026. And persistent moisture, slough that keeps on coming back because it's not random. These are signals from the Pseudomonas aeruginosa, okay? And why does this matter in our patients that have diabetic wounds? Because the perfusion is already compromised, the immune system is already weakened. So when the Pseudomonas aeruginosa sets up its biofilm, it turns the wound into a chronic inflammatory loop. Not necessarily dramatic, but incredibly difficult to resolve. Now, let's talk about us hot tubs. Ugh, I don't even do hot tubs anymore after the more I know. So, hot tubs, we love not me anymore. But warm water changes everything. Heat plus moisture plus organic debris. That's like a perfect storm for these atypical pathogens. So these infections don't explode. They linger, they adapt, and they evade. So first, first things first, Mycobacterium marineum. This is what they call like fish tank granuloma. So this organism is in a different category entirely. It's not behaving like a typical bacteria. It's a non-tuberculous, okay, Mycobacterium, meaning that it's slow growing, it's resistant to many standard antibiotics, and often missed in routine cultures. So where does this come from? Fish tanks, aquariums, hot tubs, swimming pools that are poorly managed. Entry point would be like small cuts, nail bed traumas, minor abrasions, okay? So what is the clinical behavior? It can be chronic as well, deceptive lesions. So it doesn't look aggressive. Instead, it presents as a small papule or nodule or a slowly enlarging lesion. Sometimes it ulcerates, may spread along the lymphatics in this like sporotrichoid pattern, you know, but it's not. But it is similar, okay? And it can take weeks to months to fully declare itself. So why is it missed? Like we said, because it looks like a fungal infection. It or just like a regular chronic wound or an inflamed lesion. And routine cultures often come back negative. So patients don't always mention the water exposure either at first, you know? So clinicians will think possibly this is benign, this is chronic, this is not urgent. But the truth is that bacteria is a persistent infection hiding in plain sight. How do we manage it? It requires a particular type of antibiotics, macrolides, rifampin, or combinations of that. Long-term treatment courses, and sometimes it even needs a biopsy for diagnosis. So if you don't think about it, you won't test for it. Next are like fungal in organisms like Candida species. This is one that we'll see most often. Candida species thrive in moist skins, interdigital spaces, macerated wounds, and under occlusive dressings. And then the clinical behavior for these Candida species are white, soggy maceration. They have satellite lesions, itchy, burning, delayed epithelialization in the wounds because it doesn't always destroy the tissue, it actually mostly prevents the tissue. And why does this matter? Because in our diabetic patients with their high glucose, it's ideal growth for this type of environment, impaired immunity, moist wound environment. So the candida becomes a chronic barrier for the closure wound. Now, another thing we got to think about is mold contamination. It's rare, but quite dangerous. I actually had a really bad case of that with a patient. So this is less common, but it happens and it's quite serious. So common contexts of getting these mold contaminations, contaminated water sources, blood exposure, poor wound hygiene, chronic untreated wounds. Clinical behavior can look black, gray, discolored, necrotic appearance, poor response to standard antibiotics, can invade deeper structures. So some mold can become this invasive fungal infection, especially in diabetics and immunocompromised patients. And the red flags that we should never ignore is if the wound's not responding to antibiotics, if there is unusual discoloration, rapid deterioration in immunocompromised hosts. Sorry for the background noise. I am near the window because it's hot. History of water exposure or contamination. So, what does water do to a wound? Water doesn't just bring bacteria, it actually changes the wound environment itself. So, most time it can macerate the wound, right? So the skin becomes soft, fragile, white. The barrier function is destroyed, the entry points for the pathogens. There is biofilm activation, so the water exposure encourages microbial adhesion, and it can and what am I? Oh, forgive me, I'm so tongue-tied. Biofilm activation, so that would cause more higher antibiotic resistance as well as chronic inflammation. And then water can also cause oxygen disruption. So prolonged soaking reduces oxygen diffusion. So, we already know a lot of our diabetic wounds are already hypoxic, so it can worsen the ischemia. So that's why oh my gosh, yeah, that's why I don't agree with like I've had patients that been told by other I don't even know who they are because I know they're not physicians, but to soak their foot. And they're just like, no, you're not supposed to soak your foot in water. You're not supposed to do that. Like, who told you that? And like, these are people giving medical advice. And I'm like, I know that's not a doctor who said that because that doesn't make any sense. That's not that we all know that's not right. You're not supposed to soak your diabetic foot with a wound in water, like regular water. You're not even supposed to be soaking it in the first place. But okay, well, to each his own. I just know. Okay, forgive me, whatever. So diabetic foot in water. This is where it gets dangerous. So, our diabetic patient in water, they may not feel the trauma secondary to neuropathy. They may walk barefoot, so that can cause microcuts. That's why I always tell patients, especially, I want you to live your life. Hot girl summer is coming. You know, just wear your shoes, okay? Wear the right shoes, no flip flops, protective gear, right diabetic shoes, okay? May expose an existing ulcer unknowingly, okay? So now combine that with delayed immune response, poor circulation, and a high glucose, which will help fuel the bacteria. It can go from a beach day to osteomyelitis within 2 weeks. And this is not fear mongering. This is prevention better than cure, education, the more you know with the rainbow. Okay, so let's do a quick case study. Forgive me, I just got a call. So, 58-year-old diabetic patient, small plantar ulcer, went on vacation, walked barefoot on the beach, entered the ocean daily. Okay, 3 days later, there was increased pain, rare, which is rare when it comes to the patient having neuropathy. So that's a huge red flag, swelling, and then there's these hemorrhagic bolus formation. Most likely, we took a culture, came out Vibrio and outcome was IV hospital admission, IV rapid debridement, and ICU admission. Okay, so the water exposure history can save your limb and life. So don't ever forget to tell your doctor that. Okay, if you had water exposure recently, even if it's a water hose. Okay, just tell us. Okay, so how do we think clinically when we see a wound? Ask what has this wound been exposed to, not just duration, size, and depth, but ocean, river, hot tub, or pool. Like, figure out because this can change the entire antibiotic strategy. So, management most likely will have to irrigate, not soaking. Irrigation and soaking are two different things, okay? Debridement and culture, deep tissue to culture if possible. Empiric antibiotics, is tailored based on the environment. If it's salt water, you have to color Vibrio. If it's fresh water, you have to color Aeromonas or Pseudomonas. And advanced care is biofilm management, moisture balance, not excess moisture. We don't want that in offloading, okay? And patient education is very big deal with this, okay? You gotta tell your patients no ocean with open wounds, no pools with ulcers, no hot tubs. Even if it's a small cut, it can go crazy. It does even if it doesn't hurt, Still don't do it. If there's a broken skin, if there's skin broken in barrier, the water is a risk, okay? So we all love us some water. Water is quite powerful. It shapes landscapes, it sustains life, but in wound care, water can invade, infect, and destroy. So the next time the patient says, "Doc, I went for a swim," you need to hear something deeper, okay? You need to listen, ask the right questions. A possible shift in microbiology is happening, a change in prognosis, and a warning. Because in this field, we don't just see wounds, we see where they've been. So this is Diabetic with Files. I'm Dr. G, and take care of your take care of your feet because they take care of you.